Left or right hand?
Stool? You guys got a stool?
No, you want the gamer chair?
No, stool.
No.
Take it.
Draper's here?
For the instruments?
Why?
For the. No?
No, it's not here.
It's not under the sink?
Is that a seat?
I'll try to touch.
Somebody tell me in the back?
You already recording? Mm-hmm. Okay. So, Jamie's recording this audio.
Good.
Alright, what we got over here, guys, is a makeshift, and you want to get all the stuff that you don't need and start putting it into an area that's just out the way. Alright, what I have set up here, I set this up earlier. Bernadette set it up, right? Okay. It's kind of set up how you need it. You got your basic instrumentation to get into the leg, okay? Do you need a Mayo stand for this? Yes or no? It depends. If there's a lot of assistants here, if it's just a surgeon and an assistant and other people, you want to set up just like this, okay? Excuse me, guys. You want this setup because you will be here assisting the surgeons here, okay? In this case, you're also going to be here, but you're not going to have that much room, okay? So whether you want to be in here or out here, if you're going to be here, you can place your Mayo stand up there. So I'm going to suggest you do place your Mayo stand up there. You can assist your surgeons from here. Remember, and always check. So go ahead and put out all your stuff. So, like I explained to Bernadette, you want your basic stuff there, and then you want your orthopedic stuff. The next thing you're going to be doing, once you expose, once you got to the bone, remember you want to do what to the bone?
Elevate it.
Yeah, elevate it.
So this is a what?
Elevator.
Key periosteal elevator, right? What other elevator do we got that surgeons love?
Freer.
Freer, right? Cobb is for where?
Joint.
Total joints. All right, so total joints. Following that, you might need to clean up the site. So that's why we have curettes and rongeurs. This is for clearing up the site. If there's fragments or areas that he needs to chip off or totally get off, these are where osteotomes are going to be needed. Always make sure you have a mallet near your osteotomes. Again, why? Sometimes the doctor needs to break off bone and literally eliminate some portions of bone that are totally shattered. So he might need to osteotome to reshape in the bone. Once he gets all that done, periosteal elevation, cleans it up, he's going to need to expose the bone. And how do we do that? What are these called?
Elevators.
Elevator retractor.
Elevator retractors. In this case, what's the name of these guys?
No.
Homins. Baby Homin, regular Homin. For this type of break right here, we got more than likely a tubular type fracture of the diaphysis. Are we going to need the baby one, or are we going to need the medium sized one? Medium size, right? We can use things like Bennett's and Chandler's, were even be great ones, which are in the other set. Okay, that's one. Once we get in there, we're going to need to stabilize. How do we do that? Pins, right? And this is again a K-wire pin and a Steinman pin. Usually above the 0.54 in size is going to be Steinman. Anything bigger than that, Steinman. Anything lower than 0.54 or 0.64 is going to, sorry, anything bigger than 0.64 is going to be Steinman. Everything lower than that is going to be K-wire. Okay? So again, it all depends. We have possibility of using possibly K-wires right now. Any bigger we start going to femur, it'd probably be these big guys, okay? So we're going to be using a small K-wire. How do you put these inside? You just stab the patient? No. We got to drill these in, right? This drill won't work. Anybody know why?
It's too small.
Not only is it too small, we don't have the right adapter, but this needs to go through the drill too. So the appropriate drills for this is going to have an opening through and through so that the wires can slip in case we need to do a short and then back out and then finally finish. So these things are long, right? And we don't want to start off here because what's going to happen? Wobbly. Remember I was telling you like that doctor wanted to hold it here? I was like, no way. And I got a drill guide. So these should also have drill guides. If you don't have the right drill to go all the way through and chuck, you're going to need some sort of guide that's going to hold here so that he can go ahead and move throughout, okay? I want to show you guys an example of a chuck that is meant for pins. This is a pin chuck, a pin collect, and this will actually attach to your drill. And the way it works is when you place this inside, okay? When it's inside, you actually grip it. This provides force and it actually pinches the pin inside. This is a little for a smaller one. The wire collet would be for the K-wire and the pin collet would be for the Steinman pin. Make sense? Steinman pin, K-wire, wire collect, pin collect. And you'll see when I put the pin in there, it's smooth, but also when I lock it down, go ahead and pull that out. You can't. Again, this chucks it into place. So the doctrine, why is this? This is a fast chuck. So you can go ahead and drill, move, chuck, drill, move, chuck, drill, move, chuck. It's for a quick access, okay? So you'll see these a lot when you use pins. So definitely have this one ready. If anything, this should be the very first one that's attached to your drill. Again, guys, if you're a good surgical tech and you're doing orthopedic procedures, attach your pin or wire collet first, so you can go ahead and throw down some wires for stabilization, okay? So we'll leave that here. We'll leave that here. Once you're done doing that, right, your doctor might need a plate. So we created a little plate here, me and the last classmate that was here. This is a 1, 2, 3, 4, 5 hole plate. If your doctor asks for a 6-hole plate, how many holes are going to be there? 6. 2-hole plate.
2.
Got some from the hardware so we can practice a little more. 2-hole plate. You'll see some that are flat and tubular. Okay? That's where you're going to have to notice the bone. What part of the bone is he going to plate this? If it looks like the flatter part, because remember the tibia does have flat parts, you might want a regular standard plate. But if you're going around certain areas that have more of a round, there's tubular plates. That means they're half tubular or circle-like, so you can put around. So definitely take a look at that. A regular standard plate compared to a DHS, okay, or DCS plate, okay. Have you guys read those or heard of those in the book? I know it is because it's in the book. But a DHS and a DCS plate, that means it's dynamic, okay. Anyone here heard of dynamic?
What's the CS?
The CS and HS, it's dynamic hip screw or a dynamic compression screw, okay? They kind of mean the same thing. When it's dynamic implants that we're using, it means it's gonna bring one end closer to the other. Meaning we're gonna put something through this one to get to this one to pull it to this one. And that's why some of these screws have threads on one side and none on the other side. Meaning when you screw, it's going to pull this end in closer to this side. That's a dynamic hip screw. Dynamic plate or compression plate and screw. This is oval. So that when you put it on one plate, let's say here, and then you put it on the other one over here, you can actually bring this closer or further apart, depending on where you put the screw. So if you put the screw, let's say, because of the tissues, because of things that are around that you can't really close the gap, that the doctor will put a screw in here, right? Another screw over here for this side, he'll loosen this one, press them together, and then tighten it down, which that means you can tighten it over here. So that's the dynamic part. Again, bringing one side closer to the other side. And by doing that, we'll put a screw here, loosen it, and then bring it over, and then tighten it over here. That's why it's oval in shape. You can start here, press it this way, and end here. So that's a dynamic type screwing. So definitely these might be available when you're doing these, because guess what? If we break your main bone on your leg, what does the rest of your leg want to do? It's going to want to contract back. Why? There's tendons and muscles that are giving you tension. Okay, so definitely you're going to need to over-express yourself, extend, distract, and then let it clamp down. And sometimes we need to extend it for a little bit and then dynamically bring it back to where it's supposed to be. Okay, so that's this one. Once we place this, we should be able to grab the bone and the plate. So we should have, sorry, I'm heating up a little bit. So we should have bone and plate clamps that are going to clamp the bone and the plate. But there's going to be things like easily known as lobster claws. These are all called reduction forceps. Reduction forceps. Whether it's a lobster claw, whether it's a Thompson, whether it's a Loman, there's a lot of bone holding bold reduction clamps. And that's to hold bone in place so that we can grab, distract, approximate, or hold plate with bone. Okay. The Verbruge, it's more cool names, right? The Verbruge is the best one for the plate because it actually has a little flat end plate and it has a curved claw on one end. And that's the Verbruge. And it is kind of adjustable if need be. So they like to use the Verbruge a lot. Yes?
When does it become a tenaculum?
When it becomes a tenaculum is when it actually is meant to puncture through. The lobster claws, the reduction forceps, they do have clamps, but they're not necessarily meant to grab the bone. If anything, it's meant to go in between a little hole to grab and then go beyond the bone and then grab. So really, it's not really meant to pinch because you can crack bone easily with, again, stainless steel. So a lot of times it's just a simple grab or hold in place when they use those. It's better to use the bone holders or those big bone reduction clamps compared to those, they look like towel clamps. Nobody likes to use those unless they really need to keep something on because the bone might be slippery, the plate might be slipping off for some reason, then they'll use those tenaculum type reduction forceps. The time that I do know they like to use the tenaculum forceps is when they have a bimalleolar fracture, okay? Again, you guys know at the ends of the tib and fib, there's these little kind of foot bone plates at the end, right? They kind of keep your joints. Same thing on up here. You got a little bone here and a little bone here. A lot of people fracture those and don't even know. But there's two little ones here that stick out, just like this, two little bones, and they keep your metatarsals and stuff in place. People, when they roll their joints, they end up breaking those off. So what they do is they grab a giant towel clamp and they'll grab those two together, keeping them together, and then they'll put a screw through and through, holding those in place. Okay, there's more beyond just that. I just gave you a brief explanation. There's a lot more surgery beyond that. All right. And then when we're ready to screw, it's going to be this action. Drill. Measure. This is not the instrument, but I made one. Tap. Screw. Okay. Drill. Whenever you drill, you want to make sure you do what? One size smaller. If you're using 3.0 screws, you use a 2.5, half size smaller. Okay. Again, if you're doing, I forgot the name, a lag screw, you're going to hear lag screws a lot. A lag screw, you're going to have a size 3.0 screw, a 3 drill, and a 2.5. The reason why it's a lag screw is you're doing that dynamic compression again. You're making sure that the screw falls through the first hole but catches the last one. So it's 3 screw 3, so it falls right in. Over here it's 2.5, so the threads catch that and it starts pulling the threads closer over here. That's a lag screw. That's the only time you'll use the same size drill, when you want screws to fall through. Okay. So, but in this case, we're using 3.0, right? 3.0, that's what you picked, right? Good. 3.0 screws. And then we'll go ahead and measure. We should have, again, there's usually a little caddy and they're all by size. Please read off your screws. Your screws are either going to be cortical or cancellous. Okay, you guys know the difference between the two?
Yeah. Cancellous, fungible, cortical.
All right, good. So why do we need different size screws?
Different material.
A different thread. One's gonna grab more, one's gonna grab less, okay? So if you have a cortical screw, you're gonna see a lot of closer screws together. Why? There's gonna be a lot more grip on that hard bone. When you get to spongy bone, you're gonna see the threads be a little bit wider. Why? You at least need to slip through that spongy bone, at least need to have some sort of grip. The more you go smaller and smaller, the more you create a hole, if that makes sense. The more you have a wider thread, the more you're not creating the hole and you're kind of threading through. I don't know if that makes sense or not. It's like a drill. The threads are really close together, it might just create a hole, okay? So with cancellous bone, it's okay because it's really hard bone, so we just screw. When it comes to cancellous, we need the screws to be a little wider, okay? Understand that. More than likely, you're going to be going through what bone to attach these two? What type of bone?
Oh.
Cortical. So make sure you have cortical screws. The only time you're going to need to, cortical. The only time you're going to need cancellous screws is when you're at the ends of bone. Because the ends of bones are usually comprised of what? Spongy bone. Again, epiphysis is usually what? Spongy. And then down to the diaphysis, it's harder bone. In this case, we're on harder bone, so we use cortical screws. When you're at the head, when you're doing something like a Cole's fracture, you guys know what a Cole's fracture is? Yeah, a lot of people that fall on their hands, right? And then the bone goes up this way. Then we need to pull down, pull the arm and distract, put screws in on the head. You'll need to put a lot of cancellous screws because of the softness. And then on the shaft, you'll go to cortical screws, okay? You see the things that I brought, there's a bunch of distal plates. It looks like this, but it has the head of the radius up here. Cancellous, and then cortical on the inside to the shaft. Also, make sure you say the size. So if I'm drilling and I say, okay, I drill, I measure, this is a depth gauge or made depth gauge. You'll go inside the hole, slide this through, and it's going to give you the number, okay? The number is either going to be something like a 12, 16, up to 18, okay? If you're doing hips, they're going to be something like 33, 64 even, big sizes. So you're going to get low numbers. Please make sure you read the top of your caddies to make sure it is that cortical screw and the size also. Remember, it's a 3.0 in diameter, and you're also going to give the length. So 3.0 cortical screw, size 16, right? That's what it was. 3.0 cortical screw, size 18, if that's what it is. 3.0 cortical screw, size 12, if that's what it is. Okay, always give back that number. Same thing with the drills, 2.5 drill, 3.0 drill, just in case. You don't want to make the mistake. A little good hint, whenever you have a caddy, pick up the caddy and look at the bottom. If the screws go like a slide type action, then they're all in place. But if you see a long screw here, short one here, a long screw here, someone in SPD messed up and didn't put those in correctly. Most caddies are going to have a little drill or screw measure where you put the screw right on top and it'll tell you the size of it. I wish I had one so I could show you guys. But literally you're going to grab it, you're going to put it on top, and it's going to say right there, oh, it's a size 12 in length. The bigger ones, of course, size 32 in length. So it's pretty cool. All right. So these are going to be different type screws. A little hint, bone wax. I know I had bone wax. Do we have bone wax in there? Let's see if we can find some bone wax. I'll see if I can find bone wax. If you guys can check in there, see if we have bone wax or in the sutures in a second before we get started. All right, and these taps are all going to be different sizes, guys, different shapes, but literally this one's a hand loosened one. You can just loosen with your hand. The ones in surgery are not going to be hand, they're going to be chuck. This is a key chuck, so you can go ahead and tighten it up this way, okay? Tap. A tap looks like a screw, but it's really sharp, so be careful. This is to make your thread on your guys' bone, okay? All right, other things that I want to show you guys here, pin cutters, right? We need to cut the pin. We have a corkscrew or another tap for the anchor that I showed you guys the other day. So this is the tap to create the screws first, and then you go ahead and put the anchor down. These are regular screwdrivers, okay? The ones that you get in your sets might look like this, but they'll also have a little spider catch on the end, so it can grab the screw while you're screwing. And you'll slip it back, so you can continue. In this case, that's why I want to show you guys the bone wax. You dip this in bone wax, and then you put this on so that way it stays on. Right now, it's staying on because some of them are magnetic. Okay? This is slightly magnetic. Over here we have different drill sizes. Your 2.0 is going to be your usual size. Over here we have a 3.0 if you want to see the difference between a 2.5 and a 3.0. And then I want to show you guys these. You guys know what these are? Femoral nails. These go down your femoral shaft when you break your femur right down the middle. Okay. This is pretty easy. You'll drape like you do the hip. They'll make an incision into that where your greater trochanter are. Your greater trochanter is you have your hip, this part right here sticking out, a little bone is your greater trochanter. They'll make an incision. They'll go with the guide pin. They'll ream. Once they ream a little bit, there's a little jig that this goes in, and they will hammer this into your foot or your leg. Sorry, not foot. And this will stay inside. They either put a screw in between here, and then to lock it in distally, they'll put a screw in here. This is where you definitely need C-arm, because they're gonna have to make a hole in here somewhere and guess where they're going. So to make an incision, C-arm guess, drill, drill, drill. I'm in. And then they go this way and they're like, oh, I'm not in. Oops, I'm right on top of it. Okay? So it's hard. That takes the longest to do. But I want to show you guys here different sizes, different ages. And on infants and on children, we won't put these in. We'll put in elastic nails. It is a nail that you can bend, and you'll put it in the leg so the kid can grow with it. But it does come out within a couple weeks too. Okay. A new age technology that we use is we use magnets, so that they can, if there's a really bad break and the kid's not going to heal in a while, or they try to derotate their legs because they have malformations, there's a little magnet in here that they'll come to the office and the doctor will put a giant magnet, twist, 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 and it'll open up the leg. Every 2 weeks they'll come twist, 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 twist with the magnets. That's a new technology also. Okay. All right. Any questions? Ready? Yeah, please.
Where did you say that?
In the suture thing or in the suture pack?
So can you hand me the thing, please?
Oh, I had some stuff. Bone wax, guys. Usually going to be found inside orthopedic packs or with orthopedics. Every time you have a broken bone, exposure of bone, you have cancellous exposure, please pick bone wax. Okay? Especially during spine. In spine, they like to put in they like to put in pins to help distract or hold the spine in place. But those things will go away and you'll have holes there. So how do they, again, cover those? Bone wax. Put in a little piece of bone wax. It's not only hemostatic, it covers the area. There's no chemicals in here that stop bleeding. This is pretty much a plug to the hole you have created. I like to make little Hershey's Kisses. Make the little Hershey's Kiss. You grab a little peanut. You remember a peanut? Put it on the edge of an instrument, and then you just apply that little thing on, and it's a little Hershey's Kiss. So that way, if need be, if there's a hole and the doctor makes a mistake, he puts it into the hole, and then he shoves the rest back in.
And then that just stays?
It stays forever. Okay, your body can't metabolize it. A lot of times when you do, and you crack the chest open, for it not to bleed and to maintain the cells, you put bone wax on the edges of the sternum. And you crack the chest open. So we'll talk about that during cardiothoracic. If not, if you don't do any of those, just make little tiny bone wax balls. Pass it around. Some of these are really hard, so what you guys need to do with this is play with it, like Play-Doh. Some of these come and be like, oh, that's hard. Literally knead it until it becomes really, really soft. Okay. I like to keep a little piece of this over by where my screws are at. Again, why? Dip, little spin, keep some bone wax in there. And now when you load it, the bone wax helps you keep that screw in place. Okay. You're actually going to press down. I give this a little tap when it's in the little carrier. So you have a little carrier, you get the screw, and then you tap. And this should get it right in there. Making sure you put your hand and you can hand it to the dog. Okay? All right, so let's do this. Fast paced. See if you remember all this.
It's like, what are you giving me, your gum?
You're probably going to live right here. Marking. What is this? You didn't write this down? You didn't label this?
I did not.
Okay. Well, you'll explain to the family. Knife. This is Melinda, right?
Oh, I was just gonna say that. I was just gonna say that.
Time out.
Time out.
Where's the nurse? Who's the nurse in this room?
I have like 3.
Anyone?
Time out.
Time out.
Who is this?
John B. O.R. We're doing an O.R.F. on the left ankle. 204 pounds. Allergies, no allergies.
Okay. So no peanuts in here. Alright. Sounds good. Don't forget your timeout, guys. Don't forget also that your sharp zone is a neutral zone. Sharps don't live there. Because that's going to happen, you're going to get cut. Okay? Alright. Timeout's good. Do we have implants?
Yeah.
C-arm?
Yeah.
Where?
Hmm?
Where is the C-arm? Is it draped?
No, it's not
So what do you want to say?
It's not right.
Don't just say yeah for the practice of saying it. Actually look and ask and say. So no C-arm. Let's get the C-arm. Make sure you get the C-arm drape. Okay, go ahead and cut.
Oh my gosh, it looks so cool.
Am I not plugged in? Nurse!
Who's the nurse for that?
3 nurses and they all failed.
Is that plugged in?
That's a mouth, please. See this action? Oh my God, there's all this blood all over the place. I wish there was something that I can just... Oh, thank you. You gonna leave that Bowie tip unprotected?
Jeez, I failed.
Can we test it? Pay attention to what's going on. Deb? So much smoke here. Dab, please. Where's your suction tip?
I don't have one.
What do you mean you don't have one?
I don't have one. It didn't come with
I
one.
saw one.
There's, it's supposed to be in your, yeah.
Dab here. Dab. Okay. Scissors a little too low. It's contaminated.
That is. Oh, that is.
Yes, it could. Ask for a new one.
Okay. Can I get a new Toby?
Somebody, don't run. Send. Another. Hold here. Okay. Dab. Dab. Dab.
Doctor, is that the sub-Q still?
Yeah. USA? You know what we learned? You changed positions, so you shouldn't have changed positions. We were here and ended up over here.
Okay.
Yes, be careful. You need to move because you can't see or something's going on. Let him know before. Sharp's okay now, right? Why is sharp okay now, guys?
Has to pump onto the bone.
So
Or the-
cute. Knife? Is this the same knife we used on the skin?
No, it's not.
Look at the way to pass it to me.
You gotta put a different blade.
New blade, please.
Perfect.
Control. Send. Send.
You can't use your finger, right?
Huh?
You can't use your finger?
I can't find the break anymore. Knife. Reland.
Bernadette, what do you want?
Another. Another. Scissor.
just sit on the back. I think she should just put it on the back table.
Maybe I have no break. I know I made a broken one.
You like wrapped it up and twisted. Scissors?
Yeah. Too low. Right? This is why you need X-ray.
Mm-hmm.
Oh, Wheeler?
There's one more.
What? Pick up. See anything bigger than this?
That's nice.
Freer. Freer. Make sure you shut past the sharp side, okay?
Sharp side.
So one thing is once they find the bone, guys, you're gonna try to lift up on the periosteum. Okay, we're gonna actually try to look at the bone. The edges. You got a key elevator?
I'm sorry, what was that?
Do you have a key elevator? Yes. No?
Yes.
Now they're going to want to clean up the inside. So, rongeur. Okay. Now, here's the trick that you want to use with the rongeur. You're going to want to grab a wet lap. So go ahead and grab a lap. Right there.
Okay.
Listen, you have freer? Don't do this, okay, guys?
Okay.
I'm not seeing this. This ruins your instrument. Alright, so the doctor's going to get the rongeur. What you're going to want in your hand is you're going to want to have a wet lap. Open it up onto your entire hand. Okay? So open the whole thing. Open it up. Now you're going to want to save portions because what you're going to want to do, the doctor's going to grab pieces. Okay? And what you're going to want to do is squeeze in between there and pull out that. And go inside.
Should we have a specimen cup for like pieces?
Definitely, but you're going to keep it in there. You don't have time to be doing that. You're going to grab, take those pieces out.
That's cool how you made that.
Okay, you're gonna want to save those pieces in a little small specimen cup with saline. You want to keep everything with fluid. Okay, you definitely want to keep stuff with fluid.
Sorry, no.
If the doctor needs to further clean up, then that's when you can give them a curette. That's when you can go inside and start cleaning up any tissues that might be in there. Again, some of this medial, again, those cortical bone on the inside might be infected, or especially if this was a compound fracture where it was sticking out, you might need to go inside and just clean the area up. And you're gonna want to do the same with that. Okay, so you're gonna doctor might be like here, you tap it on there or slide it here. Okay, so definitely, whenever you have a rondure or the doctor's taking out any pieces of bone, have a rondure ready for your doctor. Rondure. And then again, what do you have in your hand?
Lap. Wet lap.
So you take pieces, and you always want to save this bone. Right? And then it's got to be wet. Very good. Okay. And now when he's ready, he'll go ahead and start to see if it works. Fix. If not, he'll need to dig in a little bit further. Now I need to see the whole bone, so let's go ahead and have some retractors. So it keeps turning on the TV. Yeah, definitely what you guys can see, he'll slide back here. You see the other one? Yep. You see how these work now?
Yeah.
Just slide behind and bring the bone forward.
And what would we hold that?
Yes,
Yeah.
definitely. And now, again, we have bone holders with plates, but in this case, a simple wire. Again, like we talked about. The doctor will go ahead and drill. Depends on which way he wants to go. It seems like this way would be a best bet. And he'll drill so they can go through and through to give me some stabilization in the bone. Okay? Top of that, again, we're just gonna drill now. So let's go ahead and give me a plate. We have the pliers. We'll pretend those are the big pliers. Open it up. Do not open it up. So that's pretty much what they'll do. They'll grab onto something like that. Okay. All right. Let's go ahead and start drilling. We'll start up here. So you need to hold the top. Let's go ahead and put the 2.5 that's there. Did you fit in there? No. Okay. Let's grab one of those that are there. Yeah. So you're gonna hold the top. Very good. Anytime you drill, anytime you use power on bone, what do you want to make sure you have? Rotation. After a drill, what do we do next? Measure. So depth gauge. And you want to open it, have it open, okay? On side, direction. He needs to find both ends. That's the hard part. There we go. Slide this through. All right, let me have a size 12. And then while you're grabbing the 12, give him the tap.
What am I grabbing? Size 12.
Size 12, it's just an inch squeeze.
Oh.
Tap, tap, tap. I'm gonna throw that in with my hand. Remember,
the
bone
drill.
wax. Put it on a screwdriver.
Oh, that's right. Bone wax screw.
Just dip it in there. Give it a turn. Okay, what size is this?
Size 12.
So what kind of screws are we working with?
Medical.
So cortical 3.0, size 12 screw. drill. Alright, hold up here. Let me have for your got it. Depth gauge? Depth gauge? Remember, drill, measure,
Oh.
bring it out.
I'll do it for each of them. Yeah. Here's the-
Remember, drill, measure, that's another 12. Tap, and then you get the screwdriver. Tap, tap. What is this?
The 3.0. 3.0
Cortical screw
cortical
size.
screw used in gas
All right. So you guys get the idea.
Yeah. That was very good.
Let's go take a look.
Do you want me to stop?
How'd you make
Yes.
that?